Hi, in today's video we will be going through USMLE questions on respiratory distress in the newborn and premature breast development in children, focusing on how to approach them step by step so we can be guided to the correct diagnosis. A 30-month-old girl is brought to the pediatrician due to the recent onset of breast development observed over the past few weeks. Physical examination reveals bilateral, soft, mildly enlarged breast tissue beneath the nipples without erythema, swelling, or tenderness. The areolae are normal in size and pigmentation. No pubic or axillary hair is noted, and external genitalia appear normal. Her height and weight have consistently remained around the 60th percentile for her age, and developmental milestones are age appropriate. Based on these findings, what is the most appropriate next step in management? Now, when evaluating questions related to premature breast development, we should identify the key details given in the question, such as the age of the child, the presence or absence of other pubertal signs, the growth pattern, and the developmental status. We should focus on whether there are signs of isolated breast development or signs suggesting broader endocrine or systemic issues, and we should pay attention to clues suggesting whether the process is benign, like premature telarchy, or more concerning, like precocious puberty. The options given here are A, ongoing observation and return for follow-up appointment in 4 to 6 months. B, check 17-hydroxyprogesterone and cortisol levels. C, check LH and FSH hormone. D, refer the child for a pelvic ultrasound. E, perform a bone age X-ray. The correct option here would be A. In view of the key clues given in this question, which is the absence of pubic and axillary hair and normal growth pattern, this child most likely has premature telarchy, which is benign breast development before age of 8, commonly occurring between ages 1 and 3. It is usually due to mild estrogenization and is self-limiting. No treatment is needed, just observation and follow-up to ensure there's no progression. Let's have a look at why the other options are incorrect. Option B is incorrect because checking 17-hydroxyprogesterone and cortisol levels would be relevant if there was isolated pubic or axillary hair development, which would suggest premature adrenarche or congenital adrenal hyperplasia. And option C is incorrect because LH and FSH levels are used to evaluate precocious puberty, which involves both breast development and pubic or axillary hair. Since this child lacks signs of advanced pubertal development, this hormonal test is irrelevant. And option D is incorrect because a pelvic ultrasound is indicated if there is a suspicion of a hormone-secreting ovarian tumor causing precocious puberty. There is no evidence of progressive breast development or other signs of estrogen excess in this case. And option E is incorrect because bone age assessment would be helpful if there were concerns about accelerated growth or early skeletal maturation. Since this child has normal growth percentiles and appropriate developmental milestones, this is not necessary. A female neonate is delivered via vaginal delivery at 30 weeks gestation to a gravida 2 Para 2 mother who went into preterm labor. The pregnancy was uncomplicated until the onset of labor. The neonate weighs 1,400 grams and no antenatal steroids were administered. The amniotic fluid was clear. Soon after birth, the neonate develops tachypnea, grunting, nasal flaring, and subcostal retractions while in the NICU. What is the most likely finding on the neonate's chest radiograph? When evaluating respiratory distress in newborns, you should focus on the gestational age, the clinical symptoms, and the birth history, whether the baby was delivered via C-section or a normal vaginal delivery, whether there was antenatal steroids given, and if there was any meconium aspiration. By focusing on these points, we can narrow down our differential diagnosis and reach to the correct option. The options provided here are A, hyperlucent hemithorax, B, pleural effusion, C, diffuse coarse infiltrates, D, fine reticulogranular pattern with air bronchograms, E, fluid in the interlobar fissures of the lung. The correct option here would be D. Signs of respiratory distress soon after birth and a history of premature birth, this points towards the most likely diagnosis, which would be respiratory distress syndrome. Respiratory distress syndrome occurs in premature infants due to insufficient pulmonary surfactant, which is produced by type 2 pneumocytes. Now, the job of surfactant is to reduce the surface tension in the alveoli, preventing collapse and making breathing easier. Without enough surfactant, the alveoli would collapse, leading to difficulty in breathing, which is seen as tachypnea, grunting, and retractions. A chest X-ray for respiratory distress syndrome would typically show a fine reticulogranular pattern with air bronchograms. Let's have a look at why the other options are incorrect. Option A is incorrect because a hyperlucent hemithorax is typically associated with pneumothorax, which presents as an area of increased radiolucency on chest X-ray. Pneumothorax is unlikely here because the infant's distress is primarily due to prematurity, and there is no mention of a sudden, sharp decline in breath sounds or other clinical signs pointing to a pneumothorax. Option B is incorrect because pleural effusion is usually associated with infections or heart failure, and it appears as a fluid accumulation in the pleural space, often with blunting of the costophrenic angle on chest X-ray. But there is no clues given in this question to indicate that this infant has these conditions. And option C is incorrect because meconium aspiration syndrome typically shows diffuse coarse infiltrates on chest X-ray presenting with a snowstorm appearance. However, meconium aspiration syndrome is more common in term or post-term infants and is associated with meconium-stained amniotic fluid. Since this infant's amniotic fluid was clear, meconium aspiration syndrome is unlikely in this case. And option E is incorrect because this finding is more typical of transient tachypnea of the newborn, which is often seen in term infants after a rapid cesarean delivery due to delayed resorption of fetal lung fluid.